Okay. Okay, then welcome to the 18th session, I think, of this series. So today, children, we are going to talk about premalignancies. So as the word implies, premalignancies means something that happens before the malignancy, right? So this concept of premalignancies came actually with the discovery of certain conditions, like the possibility or the conditions, especially in gynecology. These premalignant conditions were identified when initially studies were done, and it was looked at certain cells in the samples to find that there are cancer-like changes in the epithelium. Okay, so that was how all these concepts started long time ago. It was found. Now, if you look at any tissue with an epithelium, okay, so you have the epithelium, then there is the basement membrane, okay, and below the basement membrane, there is the other blood vessels, nerves, everything are there. So there is a epithelium, basement membrane, and there is structures underneath the basement membrane. So any cancer or malignancy needs to go through, if it starts on the surface, right, it needs to go through the basement membrane and fall onto the area below the basement membrane to be called a cancer or an invasive cancer, right? Do you all understand? So that is the basic concept that you need to understand. So what was found was there seemed to be changes in cancer when they looked at the cervix, which was above the basement membrane, right? Where the epithelial cells showed symptoms or showed findings of being cancerous. So therefore, since it's not an invasive cancer, since it is contained, this entity was recognized as carcinoma in situ. Okay, that is contained carcinoma or CIS. Now, as things developed, now suddenly it's malignant, but suddenly something that is contained and has not gone through the basement membrane was found. So as things progressed and more data was accumulated and better cytology, histology results start to come in, suddenly even stages lower than the carcinoma in situ was recognized, right? And then suddenly there were entities where it is not carcinoma in situ, but something less than that. Okay, so now the concept of something happening before malignancy, right, and then it becomes maybe carcinoma in situ possibly. This does not imply that one follows the other, because we do not know whether one starts off at one stage or right. But however, these pre-malignant states were starting to come up in literature, and suddenly this understanding came that seems to be a natural progression of a disease, right? And what does that mean? Yes, there may be stages where before it became invasive cancer, there are stages that are recognizable. And thus came this understanding, which was started to be named as CIN. Okay. So because this CIN, the whole spectrum was there, not only carcinoma in situ, right? There were lower sort of categories, which is not carcinoma, but different types of categories were there. Okay, so they are also to name everything together, not only carcinoma in situ, but everything together. The term was coined as cervical, cervical intraepithelial neoplasia. So, which means CIN. Now, this intraepithelial neoplasia had in it all types of different stages. Okay. Now, suddenly, now there came a necessity to try and grade these as to what and how we should grade these things, right? And therefore, with that, the classification started to come in, right? So therefore, CIN in the older classification or cervical intraepithelial neoplasia was classified into CIN 1, 2, and 3. Okay, which basically mean how much the cells were affected, right? And then when we are looking at the cells of how affected it was, what were we looking at? And basically, the cytologist or the person who looks at these cells were looking at the nuclear abnormalities of the cells. Okay, because in the cell, there is a nucleus and there is a cytoplasm. And different types of abnormalities are there in cancerous cells, these nuclear abnormalities, right? And therefore, this term or nuclear abnormalities were coined as a name, or a name was given to that specifically, and what is that? Dyskaryosis. Okay, so dyskaryosis is the differences in the nucleus, and so this was described. So basically, when cytology is described, dyskaryosis is something that is looked at in most of the time, right? Now, what is dysplasia? Dysplasia is the architectural changes in the tissue itself, not a single cell. How they are arranged, whether they are packed close together, whether there are changes in the shape, and how they are stacked with each other. And the differences in that is called dysplasia. You understand? I'm just putting in these words for you to understand these different things. But when we are looking at the cervix and we are looking at the cytology, mainly we are looking at dyskaryosis. Is that clear? And these ways of describing these are cytological. You look at the cells and the cellular characteristics, the characteristics of cells or the dyskaryosis is described depending on the severity, right? And if you are thinking of histological, it needs tissue so that the pathologist can cut it, right? Stain it and look at it under the microscope. So when you are looking at cytological, or if you are looking at cytological things, we are just looking at the cells. We are not talking about architecture. We are not talking about different ways. You all understand? So if we are looking at many planes of tissue and we cut a sample and take it, then we are looking at a histological sample. I just want you all to be clear as to what we are looking at. So basically, yes, if we have the whole tissue or the cervix or the womb, and the pathologist will cut it, stain it, yes, he can also tell us that this patient has cervical intraepithelial or a carcinoma in situ, or whether it's an invasive carcinoma, he can tell us those things. But however, what we are looking at or what we are thinking about is a cytological diagnosis, okay? And that is done usually as a screening method. You all understand all these small things. So I will try and get things clearer to you as we are looking at things. Now, mainly when we are talking about pre-malignant lesions, we are basically mainly talking about the cervix in gynecology. Okay, because this is the time, this is the cervix has been the most widely investigated, and that has the most amount of properly organized protocols that are looking at the cervix, right? Remember, it is not only the cervix that has premalignant lesions. So you can have cervical premalignant lesions, you can have vaginal premalignant lesions, you can have vulvar premalignant lesions, right? And there's another entity where we have multicentric. It involves the cervix, the vagina, and the vulva. There are different changes everywhere, premalignant lesions, right? So these are multicentric pre-invasive lesions, right? So these are different, they are called in different ways. For example, in the cervix, it can be called cervical intraepithelial neoplasia. In the vagina, it is called vaginal intraepithelial neoplasia, right? That is vein. In the vulva, it is called VIN, vulval intraepithelial neoplasia. If you find lots of spots everywhere, it is called multicentric intraepithelial neoplasia. You all understand the terminology, right? So in this, I just want you to understand these concepts, and I want you to grasp the fact that most of these things are revolving. The premalignant lesions of the genital tract revolved around the cervix with the additions of the other things, because these are not, other things may not be very well understood, right? As opposed to cervical intraepithelial neoplasia. And there's another one. If there is glandular neoplasia, cervical intraepithelial glandular, CIGN, right? That would mean the glandular or glands that are involved in the cervix, right? So there's an entity which is also poorly understood. And even if we get that, we hardly, most of the time, it's very difficult to follow it up. It's followed up like CIN, but so these are the types of different things that you need to understand. To summarize, in the cervix children, the premalignant lesions are called, I will tell you about the other classifications later. Just remember this: cervical intraepithelial neoplasia. Okay, these are premalignant lesions. They have not gone, or they have not gone through the basement membrane. The second ones are in the vagina. What are these called? Vaginal intraepithelial neoplasia or vein. Then there are vulvar, right? Those are called VIN, VIN, vulvar intraepithelial neoplasia. And there is also some understanding called cervical glandular neoplasia, right? Right? Cervical intraepithelial glandular neoplasia or CIGN, right? Then we have multicentric intraepithelial neoplasia, right? Which is at the same time the woman has different lesions. So they have vein, vulval, everything together. You all understand, right? So when we look at all these, right? So let's get back to the start. I just wanted you to understand. Dyskaryosis means the differences in the nucleus. Okay. Dysplasia means what? Dysplasia means usually it is used in other places, but the architecture of the tissue and how cells are stacked with each other is disrupted, or if there is a problem there, we call there is dysplasia. You all understand? So these are the, and any other diagnosis, right? If you are looking at it, histological would mean the tissue itself is looked at. Cytological means only the cells are looked at. Okay. So that is the main summary of what you have to understand initially. Right. Now, let us look at screening as to how we detect these things. Right. Now, what is screening? Screening is that you can take, say, if you take a whole population. Simply put, we do a test to divide the whole population into two large groups, right? One large group is low risk. The other large group is high risk. You all understand? We simply divide it into two. right? So one large group has high risk for developing the problem, and the other group is low risk for developing the problem. That does not mean, right, that the low risk group, there may be people who is having the disease. Okay. In the high risk group, that does not mean that every person has the problem. You all understand? We simply divide it into two groups, low risk, high risk. And how do we divide this? We divide it by using a screening tool, right? So we do a screening test and we divide it into two groups. And then from these two groups, we take the high risk group and perform a diagnostic test. And what does a diagnostic test means? Diagnostic test means it is a test that is, as we have a very good chance of detecting the problem. So to the whole high risk group, we perform a diagnostic test and we arrive at a diagnosis. Do you all understand? So this screening tool is very important, right? Because the screening tool needs to be able to get most of the people who have the problem into the high risk group. Okay. And when you are looking at a screening tool, what you have to understand is, so if you are screening for something, the first most important thing is that we should be screening for something important. And that is having a huge impact on women's health and the world and everywhere, right? As the woman as well as the whole economy. So for example, if it is a very rare disease that happens once in 1 million, okay, there is no point. Of course, for the person who got that disease, it is important, right, before it happens, because it's 1 in a million. However, for the whole population, we'll be testing so many just to get hold of that. So it is not economically feasible. Do you understand? So that disease needs to be important. Is cervical cancer important? Yes. Because women die horribly, right? And a lot of people, there's quite a significant amount of women, especially in the developing countries, right, who are dying of cervical cancer. And cervical cancer, as you all understand, it spreads to the parametrium, spreads to the ureters, spreads to the pelvic side wall, spreads to the rectum, go to the bladder, and these women die with a lot of pain and suffering, right? And therefore, it is a very significant disease that we need to address. So therefore, yes, cervical cancer, or trying to find cervical cancer before it becomes invasive, right, or cervical disease is a very important issue. So we have an important disease. Breast cancer is the same. Remember, cervical cancer is the third most important cancer of all malignancies in women. Okay? Breast cancer also is very, very significant, right? So all these have screening tools. So first of all, the screening, it has to be an important disease. Second thing is that we need to have a good tool. And do we have a good tool? Yes, we have a good, simple tool, right? And what is there for one moment. Okay, so we have an important disease, and then we have a good tool for screening, which is now once we have done that, for us to arrive at a diagnosis, we also have a good diagnostic tool. And what is that? That diagnostic tool is called colposcopy. So we look at the cervix with the colposcope, and then we take a histological sample, we cut it out, okay, and we get tissue, and that is sent to the pathologist, and the pathologist has tissue to work with, and therefore the pathologist will give us a diagnosis as to what is there, whether it is invasive, whether it is not invasive, it is about the basement membrane. So therefore we will have a tissue diagnosis, and therefore when you do that, what is very important here is sometimes the tool which we use, colposcopy with taking a biopsy, which is usually a large loop excision of the transformation zone, right, is also a cure. Because if the resection margins are clear, we have cured the disease, which is premalignant, which might become malignant later on. Do you all understand? So therefore, cervical premalignancies, right, because we have a good tool and because the service is accessible, it is there, right, for us to reach, right, because through the speculum we can reach it. We have a good diagnostic tool. We have a good way of curing it, initial stages. So basically, cervical cancer treatment and finding premalignant condition of cervix has become quite a success story as far as the cancers are, cervical cancer is concerned. So the countries that have a very good cervical screening program has reduced the incidence of invasive cervical cancer to a large extent, right? Very, very large extent. And sometimes the invasive cancers which they are seeing are from the migrant population who come from other countries, right? But sometimes in their own country, if they have gone through the program, the chance of having invasive cancer falls very, very, very low. As opposed to countries like us, where we do not have a proper screening program because it's extremely expensive, right? And therefore, we still have cases of invasive, highly advanced cervical carcinoma, which is prevalent in our country and in other countries who do not have this proper cervical screening programs. Okay, so now let's understand what it means, right, about cervical premalignancies. So what was found was, right, so now we have a proper cervical cancer screening tool. And what is the tool that we are using? We are using a cervical smear, right? Now, the cervical smear, or also called the perpendicular, because it is the Greek scientist who found it and named it, right, is what? You take the cells, you clean it, then you take the cells of the squamna-columnar junction, right? And what does the squamna-columnar junction means? It means that the inside the cervix, there is columnar glandular tissue. The vagina, there is squamous epithelium, right? So they go over the cervix and then go into the cervical canal. And inside the glandular tissue meets it. So where they meet is what we call the squamous-columnar junction. Okay. So what happens is when the glandular epithelium inside the cervical canal and the uterus, which is columnar, when they go out and meet the acidic tissue, acidic environment of the vagina, as you all know, the vaginal environment is acidic, especially by the lactobacilli, they transform from glandular to squamous. Okay, and this transformation is called metaplasia, right? So the place where the metaplasia happens, which is where the glandular transforms into squamous, right, is called what? The transformation zone. Okay. So why does the vagina have squamous tissue? Because it needs to take a lot of punishment, okay, during sexual intercourse, right? And therefore it has no glands, because if there were glands, each time a woman has sexual intercourse, she'll be bleeding. Okay. So therefore there are no glands. So the vagina does not, squamous epithelium does not have glands. So there are no secretions. The secretions are from the cervical glandular epithelium as well as from the Bartholin's glands, which has small tubes and outlets right at the beginning of the vagina. Okay, and that is how the Inside, yes, there are microorganisms that produce different kinds of secrets, especially lactobacilli, which keeps the contents acidic. Now, when the glandular tissue meets the squamous tissue, the glandular tissue is the acidic environment, there is metaplasia and it converts itself into squamous epithelium. This zone, right, is called the transformation zone. Now, here from there comes another story about human papilloma virus. Okay, so actually, human papilloma virus is found in 99.7% of cervical cancer patients, right? In fact, it is unclear whether there are any cervical cancers that exist without human papilloma virus. So it's almost 100%. Okay, and therefore, what does this do? Human papilloma. It is thought in sexually active women in all over the world, right? 80% of the women, right, at some stage in their life becomes positive for human papilloma virus. But that does not mean that all these women are going to develop cervical cancer, because the body, right, of the majority of these women, the body will flush it away, throw it away. Okay, but however, in some women, we do not know why. Maybe there's a genetic predisposition, or there's a problem because the human papilloma virus lives where? In the epithelium. Okay, so when there's a breach in the epithelium, or if there's microtrauma and there's a human papilloma virus infection, and human papilloma virus infection is thought to be sexually transmitted. So the male or the female, right, whoever the partner is, can sexually transmit the human papilloma HPV to the next person. Now, when there's a breach in the epithelium, because through microtrauma, because definitely if there's sexual intercourse, there'll be microtrauma, right? So therefore, then it goes through the breach in the epithelium and creeps into the cytoplasm of the cell, right? And there it lives in the cytoplasm. So it starts to tries to replicate. But what happens is, because there is cell-mediated immunity, right? And the cell normally dies within 40 to 60 cycles. You know, any normal cell in the epithelium will die within 40 to 60 cell cycles, right? So what happens is, the cell-mediated immunity will remove it. So most women may not get really infected, or it will be removed by cell-mediated immunity. If there's a problem with the cell-mediated immunity in the cervix, right? Or if the virus slowly goes itself into the DNA or the nucleus, if it goes in, right? And it fuses with the DNA or the, what is this called? It is called integration of the viral DNA into the nucleus. And now it goes into the nucleus. And then it changes this nucleus slightly. So the changes at some point causes it to be, it cannot be eliminated. There is no programmed cell death in 40 to 60 cycles. And the cell becomes immortal, right? And then these genetic changes will occur to such an extent, it creates a cancer line. And then it starts to multiply and proliferate. And then inside the epithelium, you start to see cells with nuclear changes or dyskaryosis. And then it starts living. So as you leave things alone for a long time, this might transform itself into a cervical cancer. Do you all understand? So it is thought that the human papilloma is not all types. There are lots and lots of types, but the most oncogenic types are 16 and 18, and then there's 11 and 33. Right? Those are the for most oncologists, but the others also very, very rarely may come, right? So when this happens, so there's a natural history to the whole thing. It does not happen overnight, right? And therefore, these changes take a long time, sometimes years, for it to become invasive carcinoma. But most of the infections, initially, even if it changes the epithelium, their infection will regress. Sometimes 80%, 60, 80, 70% will regress, right? Back to normal. The woman's body washes it off. But if the changes is prolonged, and sometimes it's because of the cell-mediated immunity, because of the way HLA type of the woman, especially in other countries, if they smoke, it's thought to be a co-factor for invasive carcinoma to happen. In those women, they may go towards an invasive carcinoma, right? So this is, so, but since we know there is a the natural course of the disease, we think we know, and there's a time limit from initial infection, detectable initial infection to invasive carcinoma, and there are pre-malignant stages as well. We get the opportunity, because there are years there, we get the opportunity to find it and take it out. So that is why cervical cancer screening and treatment before it becomes invasive cancer has become a success story actually in the fight against cervical cancer. You all understand? Because we understand the natural progression, we have a good tool, we have a good diagnostic method, right? And it, at the same time, it can cure the problem as well, right? And therefore, the cervical cancer incidence has gone down when we look at or do these things properly, right? So now, what you need to understand is, let's look at a few things that you all need to know. Number one, all right? So we have a good screening tool, right? But now the world has gone away from the cervical smears way which we do, because what do we do? We take it on from a stick-like thing, right? Take it and put it on the slides, put it in alcohol and send it to the lab. But this will have a lots and lots of debris. And it's very difficult for the cytologists to look at it properly, because they are looking at the cells, right? And they are looking for dyskaryosis, right? The world has moved away from these smears. And now what is best is the liquid-based cytology. And how does that happen? All the cells that are collected by a brush or by a spatula is put into a liquid, special liquid, right? And it is dissolved there. And this is centrifuged, and the cells that are actually not debris, cells are put on a slide which is a monolayer. One single layer of cells are laid out with staining, right? And that has increased the sensitivity and the chances of looking at dyskaryosis a huge amount, right? So it's a monolayer, it is liquid-based cytology, and the world has moved away from the traditional cervical smear done with a spatula and putting on glass slides. It's available in Sri Lanka, slightly expensive, but it is not available widely. But remember, the world has moved away from the normal cervical smear which we do. Is that clear? So it's called liquid-based cytology. The importance is the cells are in one layer or a monolayer after staining, and they can be looked at. And what is looked at in this, whether it is a cervical, the cytologist is looking at the cellular changes or the dyskaryosis. And then from there onwards, there are different classifications as to how these cervical smears are interpreted. America has one, Canada might have one, Sri Lanka might have one, UK has a different system, all sorts of different systems. Children, what you have to understand is, right, in the older classification, if you look at CIN 1, 2, 3, right, basically CIN1 means not much dyskaryosis and maybe not all the layers are involved, which means when you're looking at this smear, there are lots of normal epithelial cells with a few dyskaryotic cells. Okay. So the cytologist thinks, okay, because there are a lot of normal epithelial cells with a few things, this must be corresponding to what we call CIN1, where only a few layers are having a bit of problem, only the lower layers, but the upper layers are not. So then the cytologist will give us okay, this is CIN1. Okay. Then if there are less normal cells and more dyskaryotic cells, they will give CIN2. And then if all the cells are having dyskaryosis, they will give CIN2. And if the cells are showing malignant transformation, they will give cervical, intraepithelial, what is this, carcinoma in situ. Okay. So these are the range, right? So that is the older classification, right? CIN1, CIN2, CIN3. Is that clear? However, in some, there's a different classification called Bethesda. What did it do? It took CIN1 with few cellular changes, mild dyskaryosis, right? And put it onto low-grade intraepithelial pneumonia, or LCL, low-grade squamous intraepithelial neoplasia. Okay, lesion, low-grade squamous intraepithelial lesion, and the CIN2 and 3 was put into one category, which was called high-grade squamous intraepithelial lesion, because this has a practical meaning. So actually between CIN1 and 2, there is no huge difference in what you do afterwards. So therefore, they were graded into high-grade lesions and low-grade lesions. So there is also one way of looking at it. Okay. Then in UK, they relied now, or they rely on something called dyskaryosis. So they have mild, the cervical smears are one, inadequate, mild dyskaryosis, moderate dyskaryosis, severe dyskaryosis, and sometimes glandular neoplasic problems, right? So different countries will have different ways of classifying their smears. So what you have to do is, remember, it's good if you understand two things. And mainly, the easiest classification with the Bethesda is what? We have low-grade lesions and high-grade lesions. Do you all understand? Right? So this is how these classifications have come. So basically what you have to understand is, starting from low-grade lesions where there is mild dyskaryosis changes, right? You have high-grade where there are lots of changes or lots of cells with this dyskaryosis, right? And there is and of course there is carcinoma. Okay. So therefore, we have low-grade lesions and high-grade lesions. Is that clear? So that is what the cervical smears are about and their classification. Now, how often do we do this for a proper screening program, right? Different countries will adopt different ones, but usually it is 3 yearly until 49 years of age, right? And then 5 yearly till 64 years of age, right? Do you all understand? So this is what you have to understand as far as the frequency is concerned, right? So next comes something, right? So the next point is, now these things that come as low grade, right? Or sometimes CIN1, right? It was found later on that they may develop into problems later on, even though they are classified initially, because every cytology is not 100%. Sometimes the sensitivity or the specificity may have problems, right? And therefore, something was introduced to try and increase the chances of catching the problematic ones. And what is this? HPV testing. Okay. So it is thought, okay, if you look at this lesion, right? With the cytology. Now, cytology, we are looking at cells. At the same time, from the same liquid, if we can do HPV testing and the HPV test becomes positive, right? With a CIN1 or a low-grade lesion and the HPV1 is also positive, then of course, these persons are also sent for to do a diagnostic test. Okay. So the approach simply, there are very complex ways of looking at it. But basically, if you look at it, high-grade lesions or CIN1, 2, and 3, right, are sent for what? Colposcopy. Okay. If there's a low-grade lesion, right, basically the practice was to repeat it. And again, we get a low-grade lesion, then you send the patient for colposcopy. The other option is you get a low-grade lesion, you do HPV, and if the HPV is positive, then you send the patient for colposcopy. If you have a low-grade lesion with the HPV negative, then you can repeat it again, right, and see whether there is a problem. Do you all understand? So that is the general sort of this very complex, this how to interpret. There are big flow charts, but basically we can use HPV to choose more people from the low-grade lesions, right, to do colposcopy. High-grade lesions, anyway, they are going for colposcopy. Is that clear? Right? So then what happens is, so we have chosen who goes for colposcopy, right? And then these people go for colposcopy. Now, what is colposcopy? Colposcopy is basically a very, very technically advanced telescope with binocular vision. As they came about, right? With them. And what is the magnification? Between 4 times to 25 times is the magnification. So in colposcopy, basically we are looking at the cervix, right? Or areas which are abnormal, especially the squamous junction, in magnification. Okay. So initially what happens is the cervix is looked at with about 4 times the magnification. And what is looked at? Very important 2 things. The blood vessels in it and the intra-capillary distances are checked, and mosaicism, how and punctuation of the vessels. Those are the things that are checked basically by colposcopy, right? And what is the most important thing in colposcopy is to find out whether there are areas of abnormality. And what are these areas of abnormality? We call them aceto-white areas, right? Now remember, when you look at the cervix, there may be whitish areas under magnification. And these may not be abnormal areas. If they are visible to the naked eye, right, most likely there'll be hyperkeratosis, more keratin there, or there may be leukoplakia, whitish pigmented patches. Okay, but there are inside, if there is abnormal, then what happens? We have to apply something to check the abnormal areas. And what do we apply? Because just to the naked eye, if it is white, they may be hyperkeratosis or leukoplakia, right? So they may not be. So what happens is, remember these abnormal dyskaryotic area cells, they have a larger nucleus and abnormal nucleus. They have the cytoplasma to nucleus ratio is different, where the nucleus is large. Okay. So when we apply sorry, one more. Right. So when we apply a liquid which is called acetic acid or an acid, it's 3 or 5% acetic acid. Okay, right? Then what happens is this remaining cytoplasm, which is abnormal, will dehydrate quickly, right? So the cytoplasm shrinks and only the nuclei are left. But in a normal cell, because there's a lot of cytoplasm and the nucleus is relatively very small, even if it shrinks, nothing much happens. But in an abnormal area, when the cytoplasm gets dehydrated, but the nucleus is very large, this large nuclei will crowd together in one clump. And these nuclei, right, which is protein, will reflect the light, right, back onto the colposcope. And that area will show as a bright, shiny, and this is what we call aceto-white areas. Is that clear? So initially, of course, when you do a colposcopy, 4% magnification, you clean the normal cell and look at the cellular patterns, right? So if they are bizarre, we think they may be it's a carcinoma. Then we look at punctuation and mosaicism, differences in that, right? Whether the architecture is changed. So we look at all those. Then if you want to look at the capillaries very well, you put in a green filter and the capillaries will become more prominent. Okay. If that also, after that, we apply acetic acid. That shows us the aceto-white areas. And what is the trick? When we see these aceto-white areas, we take a biopsy from those, which I will describe later. The next question is, we can apply after that, even to recognize the abnormal, we can apply Lugol's iodine. And it is thought Lugol's iodine colors the tissue brown if there is glycogen in it, in the cells. Abnormal tissues, abnormal these dyskaryotic cells, have very little glycogen in it because mostly it is proteins with the large nucleus, right? And therefore, when you apply Lugol's iodine, the abnormal areas are not going to take it up, while the normal tissue is going to take up and they stain brown. And this test is called Schiller's test. S-C-H-I-L-L-E-R, Schiller's test, because it is the person who described it, right? So if it is Schiller's positive, that means these are the areas that has not taken up Lugol's iodine. Okay. If it is Schiller's negative, these are the areas that have stained brown and has taken up Lugol's iodine because there's more glycogen there in the normal cells. Is that clear? So these are the tests that we perform. And then once that is done, right, and all this acetic acid, all this application is to the squamocolumnar junction or the transformation zone, which we have identified through the colposcope. Then what we do is, if there are areas which we think are abnormal, then we take a histological sample. And how do we perform that? We perform that by what we call electroloop diathermy, which is called a large loop excision of the transformation zone or lens. It has to have a bit of anesthesia, right? And it is done under direct vision of the colposcope, and then the whole phase is cut off. However, later on, we can do large loop excision, we can do cone biopsies, all these, and we can take the biopsy from these abnormal areas. So just taking punch biopsies is not enough, because then it's not going to make a cure. We have to go back again. So if you can see the transformation, you can see all the abnormal areas, you can cut it with a large loop, right? Or the diathermy or the loop, or with the cold knife, then of course there has to be anesthesia, right? Because otherwise it starts to bleed. So all that, a histological sample is taken, and if the pathologist tell us, okay, it's not invasive carcinoma and the resection margins are clear, then of course the cure has been given to the patient. Do you all understand? So this is what we do when we do a colposcopy. Is that clear, children? Right? So this is the treatment of pre-malignant disease. So in summary, I have taught you what it means, okay, what pre-malignancy means, what natural progression is, right? I have told you how the classifications came into being. I have told you different kinds of malignancy, CIN 1, 2, 3, which is not you should use. Then I have spoken about dyskaryosis, which is usually used in UK, mild, moderate dyskaryosis. So they basically fit into the other classifications also. Then there is Bethesda classification, which is low grade and high grade lesions, right? It doesn't matter what classification, because the protocols are in place. Okay, mild and moderate dyskaryosis, colposcopy, right? So moderate and severe dyskaryosis, colposcopy. Mild dyskaryosis, okay, you do HPV. And so different protocols are in place. Okay, if it is in that country, if it is low grade and high grade lesions, colposcopy. Low grade lesions, either you follow up or you do HPV. Do you all understand? Then in some countries, this cytological and HPV testing is incorporated into each other, and they go for protocols which incorporate this and that to increase the sensitivity of finding the lesions. Do you all understand? So whatever they do, finally a crowd is selected for colposcopy, and colposcopy, I told you what the principles and how it's treated, and then the either it's a cure, or if the resection margins are not clear, you go ahead again. You can do a separate cut, or you can go ahead with a hysterectomy to cure the disease, right? So these are the ones that you have to understand as far as screening is concerned. Then from there, remember, there is cervical intraglandular neoplasia, where you find glandular abnormal cells, and it's very difficult to know. So therefore, you have to again go for a colposcopy, but the sensitivity and specificity is small, because the glandular inside the cervical canal, we do not know really where they are coming from, because we collect the cells, but where they are coming from, and it's very difficult to check the cervical canal for lesions, because we can't see them from the colposcope, right? So in each case, you have to decide on different things like hysterectomy if it continues, or different types of samples, right? So that is a very different area, difficult area to treat. Okay. Then if you are suspecting lesions which in the vagina, then that is vaginal intraepithelial neoplasia. There are no specific ways of looking at it, but basically it is also from the colposcope where you can have acidovitic area, but it is not very specific, because sometimes it's very difficult to identify. Those are very difficult, controversial areas. And of course, vulval intraepithelial lesion, you can see this. If they have pruritus, itchiness, and differences, then you can look at it through a colposcope, identify, take biopsies from there. But then, if it is continued through and you are thinking of any problems, you can take excisions. But then it's also a very difficult area to see. And multicentric is even more difficult and a controversial area. Okay, so mainly treatment, pre-treatment, discovery, and everything is concentrated on the cervix at the moment, right? But you need to understand that there are other entities like vulval, vaginal, multicentric, and glandular neoplasia as pre-invasive disease as well. Okay, so that is all I wanted for you all to understand, right? So the next gynecology, now I'll do obstetric next. Please type in your preferences for obstetrics for the next week. Okay, whatever you want. So I will choose one. And then since I have started with pre-invasive things, I will start off with different kinds of malignancies, right? In gynecology, some important ones which I will do. Okay, right. So today is a short session because I am traveling early tomorrow. So anything that, any questions that you all have, I will answer now for 5-10 minutes. How do people get HPV virus without multiple partners or high-risk sexual activity? The problems here is it's not about multiple partners. HPV, I have to talk about something else also. HPV is extremely prevalent, right? A lot of people are infected with HPV. So at the onset of sexual activity, anyone can get infected, all right? And therefore, it's nothing about, you know, number of partners or the types of sexual activity. No, it's very difficult to, shall we say, it's a very common thing, right? So, but what happens is, although people get infected, it is cleared by the body. If the person has good cell-mediated immunity, it's cleared. And the other thing I have to mention is for HPV, now there are, for school going or sexually, women who are still not sexually active, right? There are vaccines, and the vaccines make use of what is called virus-like particles, right? In the viral capsid, right? The proteins which are there, when they are taken off individually, they are able to, put together, they are able to form virus-like particles by themselves. They can assemble themselves. However, they do not have the viral DNA, right? They do not have the material to replicate, but these VLPs or viral-like particles have the body responds to them in the same way to produce an immunity. So the vaccines are using the viral-like particles to create an immunity in themselves. So usually it is schoolgirls, 13 to 14, that recommendation. It has not been found whether vaccinating boys have changed it much, but in women, yes, it is recommended, right? And therefore, there are different kinds. Initially, there was Cervirex. It's a bivalent, the 16 and 18, right? After that, Gardasil, 4. That gave 11, 33, 16, and 18. And they have, for the other types of HPV also, they have reactivity. So therefore, and what is important in a quadrivalent one is, it gives protection for genital warts as well. Okay. So because 11 and 33 also causes genital warts, right? Which are growths. You know that genital warts are, right? That's also HPV. So, but these vaccines will give protection for those as well. And now recently we have vaccine, but it is not available in Sri Lanka. I think the quadrivalent is there. There is a 6 or 7 pentavalent or hectavalent. I can't remember exactly. That is also there, where it incorporates 6 or 7 or 8. I can't remember now. Types of protection, right? Or VLPs, right? So therefore, that is also available. So if the woman is not sexually active, yes, you have to have the doses. And the studies have shown that the immunity lasts from 5 to 20 years, right? So therefore, later on, the recommendation will come for booster doses. But for the moment, it is important if women, the school children, to get this vaccine if that person is not sexually active, or any woman who is not sexually active. It is a good thing to get it, because it guards against the chance of the woman developing cervical cancer at a later stage. Okay. Can you give the HPV vaccine to sexually active people? No, there's no point, because the chances of the person getting already infected is very high. So okay, give it if you think, but it's there's no point. Actually, there's no indication. We're doing pap smear in a menstruating woman. Can intervene? Yeah, you can't do cervical smears in a menstruating woman, because that will on the slide or in the Cytology there'll be all blood, and that's not going to do very well. What is the difference between loop electrosurgical excision and cold knife incision? Well, loop electrosurgical excision means there is a loop, right, which is formed in a way of say like half a circle, and through that the current goes, right? And remember, this current is conveyed onto the tissue. What happens is, in any form, so it sort of heats up, and that cuts it. So that loop can, when you move the loop, the whole cervix with the scomocolumnar junction is cut off. So it's like a cone-like thing is cut off, right? Cone knife conization is you cut it with a knife, a proper knife, okay? proper scalpel, right? But however, you will have to cauterize the blood vessels or put sutures and take a proper sort of done. So that is what is called a cold knife cauterization, right? That, of course, all these procedures will have to be done. Now, large loop excision of the transformation shown, you can do it under local anesthesia. Cold knife conization, where you take a cone, has to be done under general or a regional anesthesia, right? Right. Any more questions? So loop electrosurgical excision is something called LEAP as well. So you can do a large loop excision, which is a large loop. Then you have you can do a electrosurgical excision. Then you can do a cold knife. So there are different ways of taking biopsies. So you don't need to know the huge differences between, as far as MBBS is concerned. Remember, let's remember that, and that can be done under local anesthesia. The rest is usually under general anesthesia. Now, if you find these areas, there are ways which you can destroy these, right? So the ways in which you destroy these areas, especially if it is very abnormal areas, it is always best to get a histology sample. Why? Because it can be cervical carcinoma, right? Where it's invasive carcinoma. Then there's a lot of, if you destroy something, then you can't win. But usually in some countries, yes, low-grade lesions, which are, you can do destructive procedures. And what are these? You can destroy it with diathermy. Okay, you can destroy it with just applying heat. Right? Then you can destroy it with cryotherapy, intense cold. Right? So those are the things which you can do to destroy these lesions. But usually before destruction, biopsies are taken, and then only the destructive procedures for the epithelium is done, right? However, if these then are done, then follow-up cytology and follow-up testing is essential after 3 or 6 months to test for cure. That is one of the things that you can understand. Once a procedure has been done, 6 months to 1 year later, usually 6 months or sometimes 3 months, a test for cure is done again with either HPV testing or with another liquid-based cytology, right? So that is before, then only if it is negative, only they'll be put back into the normal cervical screening program. Okay, so that is one thing that you know. So once something is done, you have to again test whether it is cured. Can you explain the Schiller's test again? Okay, right. Now Schiller's test is done during colposcopy, right? So as I told you, remember, one of the tests is we apply, so you do one after the other. Number one, you look at it under four times magnification. You clean it with normal saline and look at the cervix. And you are basically looking at the transformation zone. What are we looking at? We are looking at, first we have to recognize it. Second, we are looking at the blood vessels, capillaries there, right? And then we look at whether there is bizarre, we look at whether they are crowded together, right? We look at the intercapillary distance, right? We look at mosaicism, how they are formed, and we look at punctuation, whether there are spots there, okay? So that is what we look at. Now the next thing is, once we do that, then we perform, see, remember, if you see white areas with the naked eye or without anything, that may be leukoplakia, whitish one, or hyperkeratosis, right? So that is not acetowhite areas. Then we apply 3 or 5% acetic acid, right? Then once we apply those, right, remember the cytoplasm becomes dehydrated from the cells, and the cells of the epithelium, because if there are nuclear abnormalities and it's a lot of proteins, right, in the nucleus, they reflect light and suddenly it looks white to our colposcope. Those are the acetowhite areas. Once that is done, right, then of course, before that, you can put in a green filter also and look at the capillary space. Then you do the acid-white areas, and we recognize those. But then another additional test can be done if necessary, which we call the Schiller's test, right? Schiller's test is we apply Lugol's iodine. Now, Lugol's iodine, if you apply to normal tissue or epithelium, any cells that have glycogen in it, right, will interact or take up the iodine and they become stained brown if the cell has glycogen in it. So normal cells have glycogen in the cytoplasm, and so they become brown. Okay. Now, in cells that are abnormal or dyskaryosis are there with less cytoplasm and no nucleus, the content of glycogen is extremely low, right, in abnormal cells. So they don't take up Lugol's iodine at all, and they don't get stained. So if there's an area that does not get stained, that is abnormal, and that is called Schiller's test positive, because it is an abnormal area. Okay. If glycogen is the Lugol's iodine is take up and the tissues stain brown, that is Schiller's test negative, because it's brown and it's normal, right? So that is what is called a Schiller's test. Okay. Right. Okay, I think we have, whoever has written this has written spelled Schiller's wrong. Okay. Please Google it. Right. Okay. Okay then. I think we are done because I have to go early. So we will. So good night then.
Good night, sir. Thank you very much.
Thank you. Have a good
Thank you, sir.
Thank you, sir.
Night.